right. I want to thank Jeff and Kim for giving us the opportunity to speak about this important topic in traumatic brain injury, or TBI. And I never knew what TRIUMPH stood for, so now I know. All right, so I'm going to get right into it. It's a long uh, topic here. So just to give you a brief outline of what we're going to be talking about, we're going to define the agitation and a few other terms. We'll go over assessment tools for grading the degree of agitation in a TBI patient. We'll talk about making a diagnosis of agitation in TBI, and then the important part, we'll go over the management and treatment options, and as equally important, the prevention and education. So to start off, the first thing we need to define is post-traumatic amnesia. So this is a definition that has evolved over time. Initially, it was described as a period of impaired consciousness after head injury. But to be more specific, it's where the patient has an absence of continuous memory or an inability to retain new information. And some nowadays would define it as when a patient can give a clear and consecutive account of what was happening around them. And the key characteristics for post-traumatic amnesia is diminished memory, disorientation to time, place, and person, confusion, reduced capability to attend to and respond to environmental cues, and significant cognitive impairment. So as far as the definition for agitation goes, there's no set consensus. That's another definition which has evolved over time. Initially, it was defined as an excess of one or more behaviors that occurs during an altered state of consciousness. And it's also been defined as a subtype of delirium, which is unique to traumatic brain injury, which occurs during that period of post-traumatic amnesia. And the characteristic behaviors that we tend to see are a combination of aggression, disinhibition, akathisia, which is also restlessness, inner restlessness, disinhibition, and emotional lability. And the third most recent definition, which is based on a 2005 review that was done, is that it's defined as a state of aggression during a period of post-traumatic amnesia. And this is the distinguishing things, that it's the absence of other physical, medical, or psychiatric causes, and it's with a score of greater than or equal to 21 on the agitated behavior scale, which is going to, as we'll get into later on, it's going to be the easiest scale to use in assessing the degree of agitation in a patient. So let's move on to agitation assessment. There's a few different scales. Some are more useful than others. Like I said, the agitated behavior scale is one of them. Another one is the Galveston Orientation and Amnesia Test, also known as GOAT. And then there's the Ranchos Los Amigos, or RLA scale, also known as the levels of cognitive functioning. Lastly, there's one called the Overt Agitation Severity Scale, and we'll go through the details of these different scales now. So the agitated behavior scale, it effectively describes the possible observed behaviors, and in the next slide we'll take a look at it, and you'll see that a lot of the behaviors that are on that scale are the ones that you're going to observe in these patients. And it's the only actual measure of agitation which has been validated specifically for the TBI population. And it comes in handy because it's helpful for monitoring the patient's recovery, and also to assess the effectiveness of the interventions that we're doing. It also has a high inter-rater reliability, which is important. And basically what you do is you rate from number 1 to number 4 based on severity for 14 different behaviors. And another key advantage to this is it's quick. You can do it within 10 minutes of observation. And here it is. I know it's kind of tiny print, there's a lot on there. But just to kind of give you a few examples, some of the behaviors which are on there are short attention span, easy distractibility, impulsive, impatient, uncooperative, resistant to care, violent, explosive or unpredictable anger, rocking, pulling at tubes, wandering, restlessness, repetitive behaviors, and excessive crying or laughing. So anyone that's worked in the TBI floor has, I'm sure, seen some of these behaviors in these patients. Another scale is the GOAT, or Galveston Orientation and Amnesia Test. It's also a valid indicator of post-traumatic amnesia in these TBI patients. And you have to get a score of 78 or more on 3 consecutive occasions to indicate that the patient is out of this PTA period, and it's a test that you can give daily. And yeah, I know this is another small size. Try to put the whole test on there, but it goes through and asks a lot of orientation questions. Basically what their name is, where they live, where they're now, those kinds of things. Um, and This is another scale that anyone that works with TBI patients is going to be familiar with. It's the Rancho Los Amigos scale. It's also known as the levels of cognitive functioning scale. And as you progress through the stages, it represents the typical progression of recovery that you'll see in TBI. Stage 4 is one that's specific to agitation. It's actually the confused, agitated response phase. There are barriers to the scale, is that the patients have deficits in attention, memory, initiation, and problem solving, and also, of course, lack of awareness of their deficits. All these things make it challenging to treat these patients. And here's the actual scale going from 1 to 8. So as you'll see, when in the initial acute phase of the traumatic brain injury, they might be in the ICU and be in the level 2 or 3 area. And then by the time they come over to the inpatient rehabilitation, they're generally up to a level 4 at least. And then as they progress, confusion will stay, but they'll become less agitated. They'll start responding to you, but inappropriately, and then eventually it'll become appropriate responses. And then eventually they usually end up getting discharged when they're around level 7 or 8 if they're able to make it that far. So the two other scales that I had mentioned are the Orientation Group Monitoring System, OGMS. It is another valid indicator of post-traumatic amnesia, but it's not brief. It takes a long time to do, so it's not really useful in your daily clinical practice. And then the last scale is the Overt Agitation Severity Scale. It's based just on observable behaviors, and it's not specific to TBI. So really, out of all the scales, the agitated behavior scale and the RLA scale are probably going to be the ones that are the most useful in these patients. So going on to the diagnosis, so using the most recent definition of TBI agitation, it's a diagnosis of exclusion after we rule out the physical, medical, psychiatric, and neurological conditions that could be contributing, and having a score of 21 or greater on the agitated behavior scale. So some conditions that you want to make sure that you rule out, as far as physical conditions, one of the most common ones is pain. A lot of these patients are in motor vehicle accidents, they're polytrauma patients, and sometimes there's fractures that have been missed. And so, it could be that they have a small fracture. It could be they just came out of, their post-op patient is post-op pain. Something else that you see in TBI patients is heterotopic ossification. So they could be developing that, and you'll see the limited range of motion when that comes into play, as well as pain just from spasticity, which is another common complication in TBI. Shoulder subluxation, skin lesions, these are all things that can come into play as far as pain goes. And then you want to make sure that the environmental conditions are not contributing. You want to make sure the patient doesn't have excessive stimulation. And I think we're going to talk a little bit about this more later on, but so limiting the stimulation in their room, having like low light, keeping the TV off. One thing that's especially frustrating is when you go into these patients' rooms, sometimes in the ICU or when they're on the floor, and they've got the TV blasting and there's nobody else around, and so it contributes to their agitation. Temperature can be it if it's too hot, too cold. A lot of times these patients are in restraints because of their agitation, which unfortunately only generally serves to further aggravate it. Also, they might have a lot of tubes and lines that are in place that's irritating them and they're pulling and tugging on. There's also something known as ICU syndrome. It's a state of acute state of confusion seen in patients who don't even have any brain injury or pathology, just because of the constant state of stimulation in the ICU with all the alarms going off and nurses coming in and out, constant lighting, and the ambient hallway noise. So even without a TBI, you can get some agitation. As far as medical issues you want to rule out, there's a good deal of them. There can be metabolic disturbances, electrolyte disturbances, thyroid, hypoglycemia, That's not unusual for TBI patients to develop SIADH. So you want to make sure that you monitor their serum electrolyte levels. They could also have an infection going on. It could be a PE. They could have urinary retention or incontinence, constipation or nausea. All these things can lead to an agitated state, and some of those can be just easy fixes. As far as neurological conditions you want to rule out, there's hydrocephalus, seizures, an intracranial mass lesion. They could just have headache that's contributing to this. And then psychiatric, we do see TBI patients with concurrent psychiatric conditions. These can be personality, psychotic conditions, anxiety, mood disorders like bipolar. And then you'll see in the elderly patients who have dementia, they could just be sundowning. So that could be another um, condition that kind of clouds the diagnosis. Additionally, there can be substance or medication related issues going on. It could be something that we're doing. It could be that when they came in, they have some acute intoxication, or it could be also withdrawal from alcohol, which alcohol is not uncommon in traumatic brain injury patients that we have, especially with the younger male patients, it seems. Um, and with the withdrawal signs from alcohol, you'll see hypertension, tachycardia, hallucinations, disorientation, of course, the agitation. You can also get it from opioid withdrawal. They'll have a lot of restlessness accompanied by abdominal pain. And then benzos, with withdrawal from that, you'll also see hypertension, tachycardia, tremors, seizures, hypothermia. So these are just conditions to be aware of and to make sure that you keep in the back of your mind when you approach a patient with agitation and traumatic brain injury. Some of the things that you could do for the workup is, obtain some basic labs, a CMP, thyroid function test, CBC with differential UA, B12 folate. The B12 folate will help you with if they have some alcoholic anemia, a urine tox screen, and of course a CT or MRI of the brain if you're really worried about like a mass lesion or something. EEG to rule out seizures, and possibly X-rays if there's a area of focal pain that you're worried about in a fracture that was missed. Also for HO, for heteropic ossification, you get an X-ray. So going into the management and treatment recommendations, the most important thing, and should be highly stressed, is environmental modification, and we'll get into that and talk about that. The other thing is behavioral modifications, which has its limitations in this patient population, and then lastly, of course, the pharmacological management as well. So let's start off with environmental modifications. So I was mentioning a little bit of this before, but you want to reduce the stimuli in the room. As far as light, noise, distractions, especially at night, because the sleep-wake cycle is going to be very important in these patients. So you want to draw the curtain, turn off the television, things like that. A lot of times the family can be the biggest source of agitation to these patients. They'll have 5, 10 people in there, and everyone's talking at the same time. So you want to limit the number of visitors to one at a time if you can. I know that can be a difficult thing to do at times, but it's really for the best with the patient. And the staff and the family should both speak to the patient in low volume, slowly, one at a time. And as I said, you want to avoid and minimize the restraint use as much as possible as you can. I know it's not always able to, but it'll help with the agitation if we can use non-contact restraints at least. Maybe some mittens or safety net beds, and having one-on-one staff supervision, which I know when they're on the floor due to limitations in staffing, that might not always be possible, but that's really the best way to go about it. And then minimizing the tubes and lines as much as possible. If it's possible, cover them up. If they've got a PEG tube, you can put an abdominal binder over that. That'll help prevent them from pulling and tugging on it. And other things that you want to do is frequently reorientate the patient. Both the staff and the family should be doing this multiple times, multiple times throughout the day and then throughout the week. Also, a lot of times it turns out, there was something, for instance, if they were in an accident, maybe they lost their glasses or their hearing device. So if they have something that you can bring in from home to help with them with that, that'll help as well. Another thing that's important is consistent scheduling and consistent staff. So that way you create a familiar routine and environment for them. And going along with that goes time toileting. And then creating that familiar environment. If they have things from home that the family can bring in, personal possessions, that does make a difference in making them feel comfortable and less agitated. Um, and another big point, this is very important, is monitoring their sleep cycle and the sleep quality. Um, these patients are often going to have a reversed sleep cycle where they're going to be awake all night and then and then sleeping during the day. So if you want, you can consider using trazodone or melatonin if it's available, QHS, and helping them get good sleep during the night, so that way during the day they're awake and able to participate. Um, and so yeah, trazodone and melatonin are generally the ones to go with. As far as behavior modifications, that's going to be allowing the patient to express their feelings of restlessness. If you have like a closed unit, that's really good because you can allow them to pace around, or if they're not safe to walk around by themselves, to be walked around or wheeled around by the staff. A lot of times they just really need to get out the energy that they have and to help them get rid of their feelings of restlessness. And yeah, so if there's a closed unit, that's helpful, or if you have some sensors, that they can wear, or on their seatbelt or on their wheelchair to make sure they're not getting up out of the wheelchair if that's a concern. Also, de-escalation techniques. Now, I'm going to talk more about that actually in the prevention and education section. So we'll come back a little bit more to that. That's also a very important area of topic. Let's see. And as far as the structured behavioral programs, they do have their limitations because it really depends on the level of the patient's cognitive and communication abilities. There's a few different behavioral programs, and I haven't really seen them used quite a lot, but one is called the ICAR model. So it's information, that's where you provide objective information about the patient's cognitive status to the patient and to the family. Contingencies is where you give consequences of undesired behavior. And awareness, so you encourage self-monitoring of the behavior. You can point out to the patient when they're behaving in an undesirable way that they are behaving like that so that they can recognize it. And then a relationship, that's to establish a relationship with the patient in a psychotherapeutic manner. A couple other structured behavioral programs are stimulus-controlled learning technique. So that kind of comes into play with what I was mentioning before with the ICAR model, where you have them, where they have to be able to recognize and respond to the stimuli that's causing an undesired behavior. If there's, certain, like a certain staff member or certain noises or something that's kind of agitating them, irritating them, learning to recognize those and respond more appropriately to those stimulus. There's also response consequence learning. It's creating an association between a behavior and its consequences. For instance, taking a timeout or token economy. And I haven't really seen that used as much, but there are some behavior programs that can be successful with these patients, and they have been found to be successful. So getting to the pharmacological management, one of the key points to remember about when you're doing medication administration is to avoid agents which slow cognition, because this is, in the end, it's going to make things worse. You're going to end up prolonging or exacerbating their agitation. And so we'll go through a few different categories of pharmacological agents, and then talk specifically about their side effects and dosages and which ones are effective for which kind of behaviors. And so, as you can see briefly, we're going to be going into antipsychotics, anxiolytics, beta blockers, anticonvulsants, neurostimulants, antidepressants. And we're going to briefly mention lithium. Its use is very limited, mainly to patients who have a concurrent mood disorder. So starting off with the antipsychotics, first thing we'll talk about is the typical ones. Haldol is the main one, and that's actually the one that we see probably used the most in the ICU or when they're on the acute inpatient ward. And I highly discourage its use. It's been shown to slow cognitive recovery, and in animal models, it's been shown to slow motor recovery, and you'll get a longer time in the post-traumatic amnesia phase. The advantage to it is it can be given IM or IV, so it's useful if the patient's going to be in acute danger to themselves or others, to staff members, then it does come in handy. But I would avoid the use if possible. And then another typical antipsychotic is doperidol. It's also available in IM. They have been studies which have found that it's actually superior and faster acting to Haldol and Ativan and Benadryl, which is a combination which is typically used in controlling acutely agitated patients. And so going further into how the typical antipsychotics are not a good idea, they have found there's cognitive improvement seen after you discontinue these agents. And then there's the side effect profile. It can be significant. There's extrapyramidal side effects, dystonic reactions. You might see increased restlessness, neuroleptic malignant syndrome, and also QTC prolongation. So you want to be careful with your cardiac patients. And definitely not recommended as a long-term agent. Like I said, if you have to use it just in the very acute setting, in case of, where the patient is a danger, then it's okay. But otherwise, I would avoid that agent. A better antipsychotic to use is the atypical antipsychotics. They have a better side effect profile, specifically quetiapine or Seroquel. Is shown to be effective in treating agitation. There are a few others as well, but the main one that I've used has been Seroquel in the inpatient rehab setting. Going on to benzos, anxiolytics. So these are another agent you want to generally avoid when you're treating agitation in these TBI patients. It can cause paradoxical agitation, amnesia, disinhibition, and then at high doses, respiratory depression, as well as impaired coordination. So it's useful, just like Haldol, it's useful for rapid resolution of acute agitation. It has a rapid onset of action, but you should generally start a long-term agent at the same time, which we'll get into some of these long-term agents next here. And then you want to discontinue it as soon as possible because you don't want to slow down that cognitive recovery that they're going to be having. As far as the benzodiazepines go, out of all of them, lorazepam is preferred. It has the less of an effect on the cardiovascular and respiratory systems. And generally the doses that you see getting used are going to be 0.5 milligrams to 1 every 8 hours. And you can titrate up, generally getting to about a maximum of 8 to 12 milligrams a day. But the less you use, the better. And then if you really do need an anxiolytic, buspirone is the preferred agent in TBI patients, mainly because it doesn't have significant adverse neurological or cognitive effects that you see with the benzos. It's non-sedating, non-addictive. It doesn't interact with a lot of other CNS agents. There are some side effects to watch out for, which is that it lowers the seizure threshold. They can get some lightheadedness and headache. There's a delay in therapeutic action as far as for the anxiolytic effects, but there's rapid neuropsychiatric effects. So it's definitely a helpful agent compared to benzos. And as far as the dosing, 60 milligrams is generally the maximum, but there's been doses much higher than that have been seen. The usual dose is generally 5 to 20 milligrams on a TID basis. And next we're going to go to beta blockers. These are a really good agent to use. Propranolol is the main one that we use. It has the best evidence for efficacy in treating post-traumatic agitation, and that's based on a recent Cochrane review. And it's also been shown to reduce the need for physical restraints, improves restlessness and disinhibition, and it's also helpful if they have a concurrent hyperandrogenic state or dysautonomic state after their TBI, which is not uncommon. And it can also be used to treat drug-induced akathisia or alcohol withdrawal mania, generalized anxiety disorder, or lithium-induced tremor. So there's multiple indications, and so you can, kill a bunch of birds with one stone, I guess. And some side effects you want to watch out for with propranolol. Hypertension and bradycardia are generally the limiting side effects, so you want to monitor their vitals regularly. It can cause depression and lethargy, but it has no adverse effect on motor recovery. The starting dose usually we see is 40 to 60 milligrams a day divided into BID or QID dosing. And the maximum dose that generally we've seen getting used is up to 420, but generally you're not going to get that high. It's going to be the hypertension and bradycardia, which are going to be the limiting factors. But propranolol can be one of those long-term agents for a little while. And as far as the reasons why propranolol is a good one to use, it's very lipophilic, so you get more effective CNS penetration. It's the most lipophilic beta blocker that there is. The two others which are moderately lipophilic are metoprolol and pindolol. So if propranolol can't be used for some reason, those are a couple other options that we have. Going into the anticonvulsants, you want to use anticonvulsants which are mood stabilizing. They're going to be the ones that help reduce agitation. And the two main ones that are generally used are valproic acid and carbamazepine. There's others which you kind of want to avoid. Well, gabapentin and lamotrigine are not as well studied. There have been reports of negative effects in recent studies, such as anxiety or agitation. And then phenytoin and topamax, you want to avoid those. They've been associated with a negative cognitive impact, so that'll slow their recovery. So going into the specific anticonvulsants, valproic acid, as far as dosing, initial doses generally started off at 250 milligrams BID, and you can titrate up as you go. And you're going to see that's a common theme, is starting low and going slow with titration up. Generally, you see the positive effects with serum levels when you get up to 40 to 100 micrograms per milliliter. As far as the limitations, you're going to want to monitor LFTs and their CBC because of hepatotoxicity and thrombocytopenia. More commonly, though, you'll see just sedation, nausea, vomiting. But if you gradually titrate them up and give mealtime administrations, you can counter that. And it's also been shown to be preferred over carbamazepine as far as negative impacts on cognition, and the side effect profile is pretty safe. And it does have potential for rapid loading, so you can administer a higher therapeutic dose at once. As far as carbamazepine, so you basically dose that up to the therapeutic effect. They've seen aggression-limiting doses starting at 300 to 400 milligrams a day, and others, there's been some variations. Others have shown it from 400 to 900 milligrams a day. The side effects of this medication you have to be aware of are hyponatremia, renal impairment, imbalance, sedation, and then rarely you can get aplastic anemia or Stevens-Johnson syndrome. So you want to measure, keep an eye on their serum levels for toxicity. But it does also have a rapid onset of action, so that makes it useful in a trauma or critical care, the ICU setting. Going on to the neurostimulants, this is another agent you can use for, that would be like a long-term agent that you want to start initially. It's effective for both acute and chronic TBI agitation. It also improves cognition, agitation, concentration, processing time, initiation and orientation sequencing, participation, so multiple beneficial effects. The dosing is generally from 50 to 400 milligrams a day in divided doses. Generally, you see it in BID dosing, generally 7 or to 8 a.m., and then the second dose, 8 to 1 p.m. You don't really want to give it generally after 1. And you'll see a therapeutic effect within several days. They did a survey which showed it was a highly preferred agent. This, along with propanol, are two of the preferred agents. And the main thing to keep an eye on is going to be, I might have more about this on the next slide. Yeah, so the main things to watch out for are increased heart rate and blood pressure. So with a lot of these patients who have concurrent dysautonomia, that's going to be something that will limit its use. And then also if they're becoming overstimulated or irritable after you start this agent, then you can back down on it. It does lower the seizure threshold. So if your patients have a seizure history or they're at that early stage of TBI when they've got increasing intracranial pressures, you want to be careful about that because that'll also lower the threshold. And then if you combine this with anticholinergic agents, there can be some side effects which get potentiated, mainly hallucination, confusion, nightmares. These are dose-dependent side effects, though, so and they're reversible, so you just back off on the dose or taper it down or off if you need to. Talking about another neurostimulant is methylphenidate or Ritalin. So it's also useful in both acute and chronic TBI. It's similar to amantadine in a lot of ways. It does have a quick onset of action and a relatively benign side effect profile. The side effect profile is going to be a little bit similar to amantadine as far as you want to watch heart rate and blood pressure on this. And as far as the dosing, it's similar dosing to amantadine as far as the timing in divided BID doses generally. And it's going to be 10 to 16 milligrams a day that you end up with. There's a couple of neurostimulants that I'll just briefly mention. I haven't really used them myself, but there's bromocriptine, which is analogous to amantadine. It's a dopaminergic neurostimulator. And then dextroamphetamine is similar to Ritalin or methylphenidate. So just a couple of other agents which could also be used as neurostimulants to help with agitation. Going to the antidepressants, so the most commonly used ones are going to be the SSRIs, selective serotonin reuptake inhibitors. It's especially helpful if there's behavioral syndromes concurrently with the TBI. Trazodone was one that I mentioned earlier about helping with the sleep-wake cycle regulation, and usually you'll start it at 50 to 100 milligrams QHS. There are some anticholinergic side effects that you can get with that, and very rarely priapism. Other SSRIs which are commonly used are sertraline, fluoxetine, paroxetine, and citalopram. Things you want to watch out for as far as side effects on these agents are going to be serotonin syndrome, QTC prolongation, anxiety, sexual dysfunction, and excessive weight loss. Definitely trazodone is the agent that we probably use most commonly because it also will help regulate the sleep-wake cycle. TCAs have been used. Amitriptyline is the most common one. The dosing has generally been 10 to 75 milligrams a day. It's not as commonly used. SSRIs I think would be preferable. It has anticholinergic effects, QTC prolongation, and it has a potential to lower the seizure threshold as well. And then just briefly to mention another antidepressant is bupropion. It's useful for restlessness, generally at a dosage of 150 milligrams a day. Alex, I'm going to briefly mention lithium. We don't really use it very often. It's mainly reserved for use with TBI patients who have mania or cyclic mood depressions. And you want to start that off at a dose of 300 milligrams twice a day and then titrate it up based on the serum levels because it has a very narrow therapeutic index. So you want to keep it within its range. Greater than 1.4 is going to be toxic levels. And it has a lot of side effects as well to watch out for: sedation, movement disorders, hypothyroid, seizures, renal impairment. So generally, like I said, you want to reserve this for patients who really do have it, who really do need it, who are, maybe have been diagnosed with bipolar before, have episodes of mania. So some key points. I know there was a lot of information there. So some key points, though, to remember is that when you're picking the ideal agent, it should be non-sedating, not affecting the cognitive recovery, and something with a low side effect profile. Start low and then go slow with the titrating of the doses up. And then you might need to, they might come to you on some agents which are actually amplifying their agitation. So narcotics, those benzodiazepines, as we talked about with the paradoxical agitation. If they're on like Reglan, any dopamine agonist, that can also contribute to it. H2 receptor antagonists or any anticholinergic medication can all actually amplify the medication. So you want to look at their med list and kind of get rid of anything that you can which can be causing complications in this aspect. And every TBI is different. They're all like a special snowflake. So treat them based on their on the types of symptoms that they're having. If they're more restless than anything else, then allow them to ambulate frequently. You know, as we mentioned before, if you're on a closed unit, that can be helpful, or with somebody that's with a staff member. And then beta blockers tend to be more helpful for this particular symptom. If they're in a hyperandrogenergic state, then beta blockers again are helpful. If they have a concurrent or episodic behavior dyscontrol or mood lability, some of those anticonvulsants that we talked about, or mood stabilizers, possibly atypical antipsychotic or SSRI. If their main thing is that they're more anxious or fearful, then Buspar can be helpful, or one of those other antidepressants, SSRIs or trazodone. And for paranoid types behaviors, the atypical antipsychotics such as Seroquel can be helpful as well. So coming back to the initial thing where we talked about the environmental controls and as far as prevention education, other things that you can do to prevent the patient from elevating their level of agitation is use social greetings. Those become cues to relax. You know, these patients aren't, they might not be aware of the proper social cues anymore, and so you have to really kind of take it slow with them. Speak calmly, slowly, briefly, clearly, and directly to them. Don't make convoluted statements. And then if they do make, you know, incorrect, confused statements, don't try to correct them. Instead of disagreeing with them, just make a neutral statement or redirect attention to another topic. You know, we had a patient who thought that we took his truck keys or his truck was parked somewhere stolen. So, you know, tell them it'll turn up. We'll find them. You know, just don't try to argue with them. And also, it's important to explain what you're going to do before you do them. You know, if you're doing vitals or procedures, let them know what's going on. You know, because they're going to be confused. That'll increase their agitation. You want to avoid any sudden grabbing or touching the patient. You want to approach them from the front. Don't come up from behind and stuff. So else? And yeah, so don't crowd the patient. And then whenever you are done talking to them, formally end it. And when you're giving the patient, when you want the patient to do something, give them a choice instead of giving them commands. And it might help to have therapies, especially initially in a quiet area. Sometimes at bedside might be better. provide a lot of positive reinforcement, and give the patient time. You have to be very patient with this patient population. They're going to take longer to process information and give a response. So just bear with them, and give them time to give their response. As far as resources, if you're at an inpatient facility, then you're generally going to have a PM&R inpatient consult service that you can talk to, or even an outpatient TBI clinic. And as far as for the patient, there's a lot of resources around. Well, not a lot, but there's some resources in Little Rock. The Baptist holds a monthly brain injury support group, and that's a very helpful thing for the patient. And their families as well to come to. And there's a lot of online resources. The one I came across was brainline.org, but there's many other ones out there. Um, so just to kind of summarize, I think that's almost all. I think that's everything I have. But to kind of summarize, initially when you come across the agitated brain injury patient, you want to identify what behaviors are undesirable. You want to consider other physical, medical, psychiatric conditions that could be contributing, like pain, infection, those things. The first line treatment is going to be environmental management. So low stimulus, reduction of anything that's causing physical discomfort, get rid of those restraints if you can, um, minimizing those lines, and reorienting them very frequently. Introduce yourself every time. Eventually they'll remember you. Hopefully, if they recover. And then keeping things consistent with scheduling and with staff. Um, and then after that, the very next step should be ensuring a proper sleep wake cycle, making sure they're getting good sleep, considering starting trazodone or melatonin if that's available. And so you do those before you start the pharmacological management. So, and then once you do decide that you want to start pharmacological management, minimizing absolutely the use of Haldol and Ativan or any other benzo as much as possible. And then the agents really that would be the preferable ones are going to be propranolol as far as beta blockers, for neurostimulants, amantadine, and for anticonvulsants, valproic acid or Tegretol. And then at the same time, being aware of the side effects that are associated with these agents, so you can keep an eye and make sure that nothing becomes a problem. Um, and then you can reassess the interventions you've been doing with the agitated behavior scale. And hopefully what you'll see is the patient will, advance down the Rancho-Los scale, and their agitation scores will improve. Then if you need secondary agents, then yeah, there's the atypical antipsychotics that we mentioned, like Seroquel, SSRIs, Buspar, and then like in very select few patients, lithium. I think that's all I have. Let me see. Yep, that's it. So I guess we can. Oh, yeah, a bunch of references.